Well, hello and welcome everybody. I'm very delighted today to serve as an opening act of a very exciting webinar today by the ISSM. The webinar will be on what is normal when it comes to sexual function. My name is Omar Rahim. I'm a urologist at the University of Chicago. I'm also the incoming chair of the ISSM webinar series. It is an extreme pleasure to introduce this topic today. I think we're going to hear state-of-the-art information and education about what is normal when it comes to sexual health or sexual function from very esteemed faculty. Next slide. So we know the International Society of Sexual Medicine, the ISSM, has been around for the last several decades. Our vision is that every human being has the right to a healthy and satisfying sexual life. Next slide. And our mission and purpose is stated in this slide. As you see, the ISSM has been around for the last 41 years, since 1982. And the whole idea of ISSM is that to provide and cover the whole field of human sexuality, including male, female, transgender, and all aspects that are important to topics of sexual health and development. Next slide. So we want to be the respectful and trustworthy source of information when it comes to development of human sexuality. We do that through different webinars, like, for example, today's webinar. We expect to have a lot of registrants on today's webinar and hopefully get the benefit of that webinar today. There are several ISSM societies, as you can see in this map here across the globe. Each society has been active and involved in the region, serve the need of the local patients and also the health providers. It's the role of the ISSM to integrate all these societies and provide a structure and mechanism whereby we spread and develop the knowledge and education pertaining to health and health sexuality. So we do that through different platforms. Certainly the virtual platform has been dominating since the pandemic and beyond. I think it provides really very instant delivery of sexual information. But we're also very proud of our 4 journals that under the umbrella of ISSM. The flagship journal is the Journal of Sexual Medicine, which provide and communicate high-level information regarding basic science and other topics and for human sexuality. We also have the Open Access Sexual Medicine Journal, Impact Factor 2.5, and also very proud of the Sexual Medicine Reviews, which is Impact Factor highest among all the journals, over 5. Again, provide really high-level reviews on human sexual conditions. And lastly, we have the Video Journal of Prostate Urology, the VJPU, which provide really very surgical techniques that pertain to surgeons that deal with sexual medicine conditions. Today's webinar, it will be conducted by a man who needs no introduction. Mr. David Ralph is with us today here, and we're very excited to have him today. Mr. Ralph is a professor of urology at University College London. He's also the chair of the andrology section there. He's been serving as a chairman and past chairman and president of very prestigious societies, the British Journal, to name a few, British Journal of Urology, or British Association of Urology, the British and European Society of Sexual Medicine, the ISSM. He's also the chairman of European Society of GU Reconstructive Surgeons. He's been awarded multiple medals and prestigious awards from multiple societies, to name a few: Brant Scott Medal in 2016, the British Society of Sexual Medicine, and the ISSM Career Award in 2022. Lately, he is also the winner of the Dr. Wilson Cup of Prosthetic Urology in 2022, and lastly, St. Peter's Medal in the same year, 2022. He's well published, over 250 publications, 60 book chapters, and many over 500 international publications and presentation lectures. So without further ado, I think we're very excited to have you here, Mr. Ralph, and we're going to hear wonderful webinars from our esteemed faculty as well. So without further ado, I'd like to turn over to you and look forward to hear your moderation. Thank you.
Thank you, Omar, and welcome everyone. I think we've got quite an exciting webinar today. We've got two great speakers. Topics to some extent, what is normal? As Omar was saying, Lillian, could you just put the next slide over, please? So we got the agenda. So we've got obviously a talk on the male, and that's from Sydney Gleaner, again, who needs no introduction. In fact, Sydney, he's chair and the chief of urology at the Santa Adria University in Sao Paulo in Brazil. And he's actually the ISSM president many years ago. I won't say how many years ago, but he's also been president of the Brazilian Society of Urology. So we okay there? Yeah. And then we've got Barbara Trebek, who's an associate professor of urology from the Icahn Mount Sinai University in New York. And she's chair of the female section in the ISSM. So she's certainly well equipped to tell us what's normal in the female. Just a little bit of housekeeping with the next slide, please, Lynn. We're going to have the two talks and then have the Q&A at the end of both talks, so that we've got about a 15-20-minute discussion on the talk. So don't use the chat, use this button that you see on your webinar, all those that you've registered. Next slide. So without any further ado, we'll start with Sydney and the male. So the floor is all yours, Sydney.
Oh, thank you very much for the introduction, David. It's a long time ago I was president of ISSM. I would like to thank ISSM for the invitation in the webinar series, and particularly to Omar, my friend Omar. It's a pleasure to be with you here today. Next slide, please. I have no conflict of interest for this talk. And before we start, we need to define what's normal. For many people, wrongly, normal is the correct. And normal it's more a kind of a statistical word, because normal means the usual, the average, or typical state or condition. So it's not right or wrong. It's a most frequent, most common condition. Normal can be defined as any behavioral condition which is usual, expected, typical, or conform to a pre-existing standard. So it's important to think who decides it's normal. It depends on many situations and many cultures and different religions. So it's not wrong or right. Next slide, please. There are some conditions that we can define what is normal as a biological states, as the penis size. This is a paper we published many years ago. We took the papers, took 9 papers from the literature, and they measured almost 6,000 patients, man's penis, and they do several measurements. The flaccid length, the flaccid girth, the stretch length that's correct with the erect length, and the erect girth. And you can see here that the average penis size in centimeters, it was the flaccid length, it was almost 9 centimeters, the stretch length 12.3, the erect length 12.7, the flaccid circumference 9.4, erect circumference it's 11.5. So this is, we can say, the average penis, we can say the normal penis size. Next slide, please. This busy table. It's from this site I refer below, and they took all the studies in the world. Some are not scientific. The studies that are presented in meetings, and they here they are in the measurement of almost 600,000 penis. So it's a big number. It's a kind of bias table, because some measurements or self-measurements the people send, how they had different methodological ways to measure the penis. But we can see here that and here they are representation for almost all the whole globe, but Africa, there is no paper from Africa. And we can see here that the average penis in the erect state, it's around 13. It's again between 12 and 14 centimeters. So this we can say, okay, the normal penis, this is the average size of a penis of most of the men. Next slide, please. Again, we can measure and define the normal testicular size or volume. This paper, they compare two ways to measure the volume of the testicle. They use the Prader orchidometer and the ultrasound, and they did the caliber against the ultrasound again. We can see that the testicular volume changes according to the age. And when the man reach the adulthood, we have a measure when you make by a Prader orchidometer, it's almost 55 ml. When you use the ultrasound, it's almost 14 ml. This is the difference is based on the formula they use for the measurement, and the caliber is almost the same. To have in 17, they have almost 21 ml. And in the ultrasound, it was around 13 ml. So we can define the average size of the volume of the testicle. Next slide, please, Lilian. It's again another paper. You can see that there was almost a stabilization during the childhood of the testicular volume. This they measure with ultrasound. When they start, the boys near the puberty, the testicle starts to increase its volume, and when they reach the adulthood, we can have around 14 ml. So for biological points, we can define what is normal, basic, or most frequent, or the average. Next slide, please. About function. Which is the normal time for a man to ejaculate? We didn't have an answer before this paper of Waldinger and colleagues, and they measured the intravaginal ejaculatory latence time. They recorded that in 500 couples from 5 countries, just Europe and USA. There was no couples from Latin America, Australia, or Asia. The criteria inclusion are men who didn't have any complaints about their ejaculatory function, and they did the measure of the ILT with a stopwatch. So when the man, the female partner controlled the stopwatch, so when the man penetrated, they turn on the stopwatch. When they ejaculated, they turn off the stopwatch. It's an artificial way to measure it. They include a lot of bias during the sexual intercourse, but it's a way to do an objective measurement. Next, please. So they find that the median IOT was 5.4 minutes. But you can see here that it is range from 1 minute to 44 minutes. There are men who didn't complain about their ejaculatory function. So again, there was a big variation according to the individuals. And they show that the ELT decreased with age. It was 6 minutes in the younger group, and 4.3 in the old man, who are not so old, but over 51. They change between countries. Interesting, because this is probably due to the cultural difference. In Turkey was the minor IOT, it was 3.7. They show that independent of the condom use, and a lot of people used in the past the condoms to prevent premature ejaculation. Sorry, and it depends on the presence of the absence of foreskin. And in the past, many people recommended a prostatectomy to treat premature ejaculation. So they defined what was the normal IOT according to the individual differences. Next, please. Another thing we can try to measure is the time between the time the man can last to be prepared to have another sexual intercourse, another ejaculation. They call the post. Sorry, they post the ejaculatory refractory time. This is what we can find in our website, and they find that they explain that after orgasm, both men and women experience a resolution stage where they cannot respond to another sexual stimulus, and during the refractory period, the man doesn't think about sex or get aroused. It depends. It's different for every man, and it changes according to the age. We know that the younger man may need only a few minutes of recovery time. Older men can need a little bit longer, 12 to 24 hours or even days. As far as I know, there is no published paper that measure this refractory time, but it's what the common sense says. Next, please. Again, another thing that we can define as a normal is the semen volume. We can find in our website, and they say that the man ejaculate between 1.25 ml and 5 ml. It's 1/4 of a teaspoon to 1 teaspoon. It's a funny way to define, but it's what is written in our website. Next, please. Next slide, please. Oh, sorry. Come back. Let's come back. Yes, thank you. According to the WHO manual, they define that the median semen volume is 3.7 ml, ranging from 1.5 to 6.8. And again, we see that there is a huge variation, but this is the normal, defined as normal. They define the normal semen volume. Next, please. We know that the semen volume change according to the age. This is a paper published by Helston, one of our past presidents. They did 2 studies based on when tadalafil was first launched, there was a worry about that it can have a potential bad effect on the semen. So they studied two groups of men. It's almost more than 1,000 men. Some of them gave 3 samples before taking tadalafil, and the other group they provide 2 baseline semen samples, and with a business time of at least 48 hours. Next slide, please. We can hear that the semen volume decreased with age from a median of 2.8 ml in the youngest age group to 1.95 in the oldest age group. This is probably increasing of the prostate, but this is a very known, this is well known, but it's according the normal can change according to the age. Next, please. When you talk about sexual behavior, this is a little bit more difficult to establish what is normal. Sexual behavior refers to a broader spectrum of behaviors in which humans display their sexuality. It includes the physiological change, the cultural change, they include the sexual arousal, include the sexual activities as masturbation, intercourse, oral sex, etc. And it can include other things that the men and women can use to increase the arousal, to enhance the sexual experience. Next, please. Sexual behavior depends on many aspects, depends on gender, depends on sexual orientation, depends on age, religion, culture, ethnicity, partnership, general health. So it's very hard to say what is normal. mainly when we are talking about normal as a correct thing. So we need to understand that what is normal in one country can be not normal in another country. Next, please. This is a paper published last year in the JSM, where they talk about the sexual debut, when a man or a woman starts their sexual activity. They, talking about men, they enrolled almost 1,100 men, young guys from 20 to 30 years old, and the inclusion criteria was they need to have had a previous sexual intercourse with orgasm, and only consensual first sexual intercourse were allowed, and they had to have an alignment of gender and birth sex. And they completed a website survey containing various aspects: the sex design at birth, gender identity, age, ethnicity, education, religion, relationship, and so on. And we got these results. Next, please. We can talking about the male. The first sexual intercourse, the average, the mean age was 17 years old. The first sexual contact, it was 16. The first sexual stimulation, 11, and first orgasm, 12 years old. And when I talk about which was their first sexual experience, you can see for the vast majority was a solitary one, which is probably masturbation, 93%. 5% had a initiation with a partner without intercourse, and just for 1.2%, its sexual intercourse was the first sexual experience. So for Canada, for those group, the normal sexual debut was around 17 years old. Next, please. This is another paper published last year. They compare the male sexual debut in Africa, and you can see here it was interesting. They compare the age, and they compare the years from 85 to 2015. It's amazing. In Western Africa, there was an increase on the age that the man had their male their sexual debut, and it went from 18 to over 21. There was a stabilization in Middle Africa along those years and under 18. And when you talk in Eastern Africa, there was a stabilization, but it's over 18. And in Southern Africa, there was a decreasing in the age where they start sexual intercourse until 2010, and after that they come back. So even in the same continent, there was a difference between the places, and probably due to culture, to religion, but it is hard to establish which is the normal for this population. There was a paper here in Brazil that showed that the male in the north part of the country starts having intercourse after 15 years old. So it varies a lot with the place and all the other aspects that I said before. Next, please. Which is the normal frequency of sexual activity? You are talking about intercourse here. So the normal frequency, it's hard to say, but it's the frequency that two partners agree works best for them. For some, that might mean having sex several times a day, several times a week, a month, or a year, depends on the partners. And it's important to say that as long as both partners are satisfied, there is no right or wrong answer. Next, please. This is a paper was published in the JSM, and after that, it was published in the BBC Future. It is how often do you have sex? And it's amazing that almost 20% of the population, that was a population from 18 to 50 to 60 years old, they hadn't had sex in the last year. 8% once a year, 28% 1-2 times a month, 40% 1-3 times a week, and 60.5% 4 or more times a week. So we can say that almost 1/4 of the population who answered the survey had a very, very low frequency of sex. And when they had sex, what kind of sex they had? For the men, 80% of the men had vaginal intercourse, 80% of the men engaged in oral sex, and 9% of the men engaged in anal sex. So we are talking about what is more common. So vaginal or oral intercourse were the most common. Probably we can think about the statistical meaning. Probably is the normal sex life of the males. Next. We can see it from the same paper. They say that they compare according to the age of the people who answer the survey. You can see that masturbation, if you're asking about during the life, almost between 70 and 90% of the men masturbate themselves during their whole life. So masturbation, it's an important part, and it's one of the most frequent, the most normal aspects of the sexual function of the male. Next, please. It's possible to define what is normal in terms of some biological factors in the sexual area, such as the size of the penis. Sexual behavior, on the other hand, depends on sociocultural factors and does not follow a defined pattern. And to answer what is normal, I think it's the correct answer is as long as people are happy and satisfied, there is no right or wrong answer. Thank you very much.
We'll just move straight on now with Barbara, and she's going to give us tell us what's normal in the female, and then we'll have some questions. Barbara.
Thank you so much. Next slide, please. So I would like to begin by posing a challenge to Dr. Glina's conclusion that normality is defined according to whatever makes a person most happy and satisfied. This Epicurean philosophy has a great deal to recommend it, especially to an audience of healthcare providers. While Epicureanism is often mistakenly associated with decadence, at its core, this philosophy idealizes the simple pleasures, safety, and absence of pain that are characteristic of human health, including sexual health, as defined by the WHO. Next slide. However, there's a reason why the term epicure is used to describe foodies rather than physicians. Historically, healthcare providers and medical scientists have not hesitated to define normality in ways that privilege certain social, political, and biophysical goals over the well-being of individual patients. This is particularly true in the case of female patients, whose sexed bodies have long been understood in contrast to a masculine norm and overinterpreted as a potential locus for moral deviance and an opportunity for its control. Next slide, please. Aristotle, a contemporary of Epicurus and Hippocrates, our great-great-great-grandfather, argued that a woman's health centered around her womb, that it was synonymous with her fertility, and that her genital secretions were merely a passive receptacle for semen, thus reinforcing the social and political dominance of man over woman. Despite multiple scientific and cultural revolutions between then and now, we continue to label obstetrics and gynecology as primary care, to justify the funding of female sex research only insofar as it is relevant to fertility, and to describe optimal female anatomy in terms of its ability to accommodate a penetrating male phallus, whether or not the body in question is personally interested in making that accommodation. Next slide. Of course, many important things truly have changed. Our understanding of anatomy and physiology has improved considerably over the past several millennia, as has our willingness to consider female sexuality as a valid concern independent of reproduction. Next slide. This talk aims to summarize what we now know about female sexual arousal, its ideal precursor, desire, and its aftermath, orgasm. Next slide. It is helpful to begin with normal female anatomy, which includes not only the vagina and reproductive parts, but also the surrounding labia and a phallus, the clitoris, which was first accurately described by Dr. Helen O'Connell in 1998. This phallus includes the small, superficial, and densely innervated glans, which was previously believed to be the clitoris entire, and also a deeper body that bifurcates into crura, each associated with clitoral or vestibular bulbs. Habituated as we are to defining the female in contrast to a male norm, it may be helpful to consider the clitoral body and crura as homologous to the male corpora cavernosa and the bulbs to the corpus spongiosum. Next slide. These internal clitoral structures surround the potential space of the vagina and urethra, which are also bracketed by various glands, the eponymous Bartholin's and Skene's glands, as well as the periurethral glands that have been controversially described as the female prostate due to their periurethral location and histologic staining for prostate-specific antigen. Next slide. In the setting of arousal, increased genital blood flow causes engorgement of the clitoris, bulbs, and labia minora, along with increased glandular secretions and passage of a lubricious transudate through the vaginal wall, described by Masters and Johnson as a sweating phenomenon. The slipperiness of this fluid reduces friction against the vaginal squamous epithelium to protect this lining and ease penetrative sexual activity. Next slide. Other changes that occur with genital arousal to support penetrative intercourse include elongation of the vaginal canal and flattening of the labia majora, which are mediated by reflex elevation of the levator ani muscle complex. MRI data suggests that this arousal response may be attenuated in postmenopausal women, though whether this is due to their hypogonadal state or some other comorbid, perhaps age-related musculoskeletal pelvic floor dysfunction is unknown. Next slide. Oh, sorry, too soon, but that's okay. It is known that vaginal lubrication with arousal is compromised by the sex hormone deficiency of genitourinary syndrome of menopause, and that this may be rectified by local hormone replacement. The degree to which age-related atherosclerosis is hormonally mediated is unclear, but vascular disease has certainly been implicated in female arousal disorder, just as it is in male erectile dysfunction. Research has shown that vacuum erectile devices and sildenafil are similarly effective at augmenting genital blood flow in both sexes. We do not routinely prescribe sildenafil to female patients with sexual arousal dysfunction, because unlike similarly afflicted men, women do not reliably appreciate the resulting physiologic changes as arousing or desirable. Next slide. There are various ways to understand the poor correspondence of physiologic genital arousal with cognitive arousal and sexual desire. with potential to give us insight into both the complex neurophysiology of sexual function and its status as an intersectional biopsychosocial phenomenon. Next slide. One is simply that penile erection is a more obvious physical and cultural signifier of sexual arousal than the less prominent changes that occur to the female genitalia with arousal. Poor sexual education, coupled with the normal changes in quantity and quality of vaginal discharge that occur throughout the menstrual cycle, can compromise a woman's ability to interpret her embodied experience as one consistent with sexual interest. Another complicating factor is that women's genitals, in contrast with men's, become aroused rapidly and reflexively in response to sexual stimuli, independent of the positive or aversive quality of that stimulus. Next slide. This has been demonstrated with both cortical stimuli, as in the studies by Meredith Chivers, in which women showed immediate genital arousal in response to films of sexual activity, regardless of whether the imagery fit their orientation and sexual interests, and with pelvic stimuli, as in Markeli Sipsky's work, demonstrating intact genital arousal and orgasm response in women with spinal cord injuries that leave them genitally insensate but spare the sacral reflexes. The prevailing explanation for this normal, immediate, and indiscriminate female genital arousal response is that it evolved as a protective mechanism in response to the ubiquity of sexual violence against women. But the discordance of body and mind is not necessarily a normal characteristic of healthy female sexual function. Next slide. Sorry, thank you. Research by Cindy Meston has shown that women without sexual problems reliably detect changes in their genital arousal response, while those struggling with disorders of arousal or orgasm fail to recognize those changes when they do occur. Spectatoring, self-critical distraction, or indeed any distraction during sexual behavior are likely to compromise one's interest in proceedings and cognitive awareness of arousal response. Gendered social norms typically foster negative body image and require women to multitask more than men, making them collectively more vulnerable to decreased cognitive arousal response and conscious experience of sexual desire. Next slide. These same social norms structure how we characterize normal female sexual desire. For most of medical history, and especially within Christian cultural contexts, women have been perceived as sex objects whose inherent lustfulness needed to be tamed within the bounds of marriage and productively directed toward procreation. Widows, and especially postmenopausal women, were a particular threat to sociosexual propriety, as their sexuality could operate in the absence of these restraints. Autoerotic and lesbian desires were similarly problematic and antisocial. Thus, the physicians and surgeons of centuries past dedicated themselves to pathologizing and suppressing women's spontaneous sexual desire, normalizing only its reactive expression within heterosexual relationships, ideally within the bounds of matrimony. This history stands in ironic contrast to our present concern with hypoactive sexual desire disorder, currently the most commonly reported female sexual dysfunction, which is defined as a distressing lack or loss of interest in sex. Next slide. Perhaps our predecessors succeeded too well at suppressing female sexual interest. Or more likely, Perhaps our epidemiologic studies are affected by social desirability bias, with a lack of sexual desire perceived to be the FSD symptom that is most consonant with ideal femininity, and therefore likely to be favorably viewed by others. Either way, it is essential to recognize that normal sexual desire, whether spontaneous, reactive, or absent altogether, is contingent on one's biological and social circumstances, and thus variable with these. Next slide. Orgasm is less culturally contingent than desire, but no less vulnerable to overinterpretation. Like arousal, it is characterized by stereotypical physiologic responses, including measurable changes in heart rate, blood pressure, and muscle tone, which are used to define orgasm for research purposes. Normally, the sympathetic tone and pelvic floor muscle spasm that characterize orgasm might be experienced as uncomfortable or even painful. But during sexual climax, they are immediately temporized by the release of dopamine and other neurotransmitters that are associated with pleasure and reward, and are followed by a pleasant muscular and mental relaxation. Orgasm is perhaps best understood as a reflex of the autonomic nervous system that can be facilitated or inhibited by cerebral input, including thoughts and feelings. Next slide. How best to trigger this reflex has long been a chief concern of sexual medicine. It is well known that rhythmic clitoral stimulation is the most direct, efficient means of doing so. But past pathologization of clitoral sexual activity, characterized as immature or inappropriately virile by Freud and others who perceived orgasm disconnected from penovaginal penetration as a danger to the heteronormative social order, led to an exploration of various alternatives. In light of our present knowledge of the deeper portions of the clitoris abutting the vagina, it is probable that vaginal orgasm, that Freudian ideal, is in fact just a variant on clitoral orgasm, especially because vaginal orgasm is most reliably achieved by women whose glans clitoris is closer to the introitus. Next slide. Kegel contractions not only strengthen one's orgasm response by increasing baseline levator muscle tone, but can also be used to aid or induce orgasm by hands-free manipulation of the clitoris. This is the physiologic foundation for the stories of girls who experience orgasm while jumping rope. Depending on the amount of glandular secretion produced with arousal and the strength of one's pelvic floor muscle contractions, a woman might squirt with orgasm. Next slide. Squirting is often a source of concern for patients who find it difficult to distinguish from coital incontinence and suppress their sexual climax in response. The use of dysfunctional coping mechanisms to counteract normal sexual function in order to achieve a socially constructed goal or goals is an unfortunate recurring theme within women's healthcare. Sometimes these mechanisms are a woman's choice to insert desiccants into her vagina in order to provide a partner with a quote-unquote dry sex experience, despite the pain and potential increased risk of infections that it can cause her. Or she might choose to undergo labiaplasty and remove healthy, sensory, spongy tissue in order to bring her genitals into conformity with the clean slit appearance that is the current Caucasian cultural ideal. Sometimes, as in cases of childhood female genital cutting and genitoplasty for girls born with differences of sexual differentiation, The choice is made for them. Next slide. For all of our patients, we have a professional responsibility to define normal sexual function and provide healthcare in ways that support sexual pleasure, safety, and the absence of pain, with sensitivity to their variable biological and social circumstances. Thank you.
Thank you, Barbara. That leaves us, it's very interesting for both talks, and we've got sort of 10 or 15 minutes of questions. There's been a few questions in the that's been put onto the Q&A. And I thought I'd just talk, I had a question, but it's also been asked on the QA by Marco Antonio Villa to you, Sydney. And that is, and we talked about penile length and normograms, but what about the variation? Because the normograms that you put up, and indeed that's what I put up when I draw a normal distribution and tell patients they've either got a normal or small or large penis, but does that vary from continent to continent?
No, it's true. If it's okay.
Yep, yeah, we can hear you.
It's true. If you saw that busy table that I showed, it ranged from 11 to 16. Depends on the paper. Depends on the area. There is a individual variation, but it's interesting that very few people have a huge penis. It's more than 20 the people would expect to have, but the normal is what we have. The most common is what we have.
Yeah, I mean, because we talk about micropenis, it's sort of 2 standard deviations away from the mean, and so that certainly from your table that would be about 7 centimeters. So, you know, when a patient comes in with a sort of 11, I say, well, actually you're within the normal, and try and persuade him and advise him that, you know, that things are normal and don't do anything. But as I said, if you're in certain countries, that 2 standard deviations is going to be more than 7, isn't it?
There is a paper from Tom Liu, and based on the penile amputation, and the penis is functional, and it can have a good penetration. It has more than 4 centimeters in the flaccid state and more than 7 in erected state. So we will consider a small penis under 7 in erection and 4 in the flaccid states. It's a way to see.
Okay.
If I could ask, I'm really curious to get your perspective on the article that was just published earlier this month in the World Journal of Men's Health, demonstrating that it appears that penises have gotten longer in recent decades. They compared the measurements from the previous century to the more recent ones and found a 24% increase in size. Not sure what.
Is that real? Or is that just the research? I think Michael Perrin was asking the same question. Yeah.
Yeah, or perhaps our measuring technique might have changed in the interval.
Yeah,
lots of.
Yeah,
it's true. I think we don't have a standard methodological way to do the measurement, so it changed. We don't know. It's a controversy. It's the same as the fertility of the men is decreasing now. The height of the men are increasing. So we don't know. We need to do more research there.
There's another question here. Do women also have a refractory time? Because we obviously know, Matt, because Sydney was talking about the male side, but what about the female side? I don't know if Barbara or Sydney, either of you?
So the evidence suggests that women do have a refractory period. Actually, video imaging of the vulva during and after coitus shows that one of the things that happens at the moment of sexual climax is that the clitoris retracts. And that's thought to be related to sort of hypersensitivity of the glans clitoris in the aftermath of orgasm. That said, unlike in the man where, that we're reliant on penile erection to engage in, the normative penetrative sexual activity, a woman is capable of being penetrated regardless of her hypersensitivity or lack thereof. And of course, sensation varies. So refractory period is present, but variably problematic for people.
Yeah. There's another question here. Let me just, I think this might be for you, Barbara. Sildenafil, do you use sildenafil at all in women? I mean, they're talking about vaginal lubrication. Is that something that you use for that?
Rarely, but occasionally. Yeah, especially in patients who have a history of peripheral vascular disease. If they report, poor arousal response, that persists despite, adequate hormone replenishment and so forth. I'll try it. I have, have had variable responses, but of course, there's the cognitive element as well that complicates interpretation of response to that medicine.
There's a question here for you, Barbara, as well, which is talking about the difference between female ejaculation and squirting, and are there different structures implied in both, in either? Is it different? I know you touched on that.
So female ejaculation or squirting is thought to come from those female prostate periurethral glands, which may or may not be synonymous with the Skene's glands. The anatomy, if you look at the history going back to Rainer de Graaf, in like the 1600s, he was the one who first described those periurethral glands in women. And then Skene seems to have stuck his name on some, but not all of them. So we think that those are the instrumental ones. But honestly, it's not a very well understood phenomenon. And of course, there is still a fair amount of skepticism in the medical and popular communities about whether it is true glandular secretion and ejaculation versus coital incontinence. For what it's worth, it appears that while coital incontinence is definitely a thing for some women, the biochemistry of squirting suggests it is not in fact urine.
Yeah, it is urine or it isn't urine?
Not, no. Okay,
so yeah. A question here for you, well, on that subject from Yuza Chen, is the female pelvic levator reflex, is that the same to the male bulbocavernosal reflex?
Maybe. So the research about the so-called vaginolevator reflex was principally done by a single scholar in Egypt. And he's published fairly extensively on these various reflexes, but it's data that hasn't really been studied to any significant extent by others. And so we do need to take it with some degree of skepticism. But it certainly seems logical.
Okay. There's a nice question here about intercultural couples, and are there more problems with their sexual lives because of their education, religion, and cultural issues? Because we talked about different cultural aspects here. What happens if you have intercultural couples, for both of you?
I think it depends on the place. Here in Brazil, we have many intercultural couples, but the education is almost the same. So I don't see many problems on that. We have some difference between different religions. So it can have a problem in the relationship. But I think if they live for a long time together, probably they learn. Yeah. What is the good for one and for the other,
and for that particular region? Yeah.
For women, there's a decent amount of anthropologic research looking at cultural norms around vulvar appearance and specifically the length of the labia minora. And there's definitely evidence of tension when a woman moves from marries and moves from a community where one labial norm is the ideal to a community where it differs. And so that sort of is always something that needs to be negotiated.
Okay, this is a question to you, Sydney, from Wirt, about penile length. Do you think with increasing obesity, certainly in the Western world anyway, is it normal size minus the layer of fat? I was thinking about the fat pad length. Did you take that into consideration when you did your paper?
I think the penis is still the same. The problem is the belly.
It's how you measure it.
Yeah, how do you measure? If the patient, the man is laid down and you press down the fat, you can see the same penile size. The problem is the belly. I used to say to the patient, your penis didn't decrease. It was your belly that is increasing. So
yeah,
the appearance for the man, it always the penis is smaller, but it is not. I think it's just appearance.
And I guess this from a research point of view to both of you, really. I mean, the tools that we have for doing these research projects are pretty limited. As you say, for your study, a ruler and a tape measure. What do you think about the new gadgets? You know, you've heard the Apple Watch, for example. The guy's wearing his Apple Watch. When his heart rate goes up, you know that he's about to climax, and etc. And the female as well. Do you think we can use some of these gadgets to get more reliable data? Because a stopwatch, as you say, is pretty unreliable, isn't it?
Maybe. I think we need better tools. Usually people say, oh, the guy has a very severe IEF, a very severe ED based on IEF, and IEF is not. It's just a frequency thing. It's not. You cannot say that it's our organic problem based on IEF. It's the problem of the frequency. We need better tools. I think we need to improve them to study sexual function. And maybe you can create a new Apple Watch for sex.
Well, there's lots of gadgets, aren't there, now coming on strong, you know, measuring your penile angle and penile size, and you know, we won't be able to move because the world is watching you, you know.
Yeah,
Omar,
David,
coming on. Are we run out of time? Are you going to give a
no, I think you're going to do the closing remarks, and thank you, David, for moderating. But I want to comment on the size of the penile. Size obviously is a very interesting topic, and a lot of research need. Dr. Glenna mentioned about new tools, but currently what we use standard, really historical, is from the base of the penis, from the pubic bone to the tip of the glans penis. That's the standard kind of measurement. But there's a lot of variation. There's people who cannot hold the ruler correctly. There are some miscalculation that happens. So I do agree with your assessment is that you need better tools. The Endopharmaceuticals came up with an app to measure the angulation and the measurement of it's an app on the iPhone, new tools, right? So that can be also used to measure. But again, I don't know how valid is that. Obviously, it has to be studied and validated on a larger scale. But yeah, I mean, measuring penises can be really tricky, for sure.
Okay. Can we carry on? I mean, have we got a time limit here? I know we've run out of time, but could we carry on? Is there any more questions we can ask, or have we run out, Omar?
I think we have time for more questions.
Okay, so there was just for Barbara, really. Do you think the prevalence of anorgasmia in females is high? Would you like to comment on that, Barbara?
Oh, well, define high. Certainly in our epidemiologic literature inquiring as to various kinds of sexual dysfunction in women. Anorgasmia is, reported anywhere from, 5 to 10% in healthy women, and up to 40% in women with various comorbid conditions. But certainly the popular literature would suggest that rates are substantially higher in healthy women. Pop culture media doesn't really report about, women with cancer and women with various other health conditions, I'm afraid. The bottom line is we don't really have great data, and especially if we take into account, again, the sort of social and cultural pressures that color report about sexuality. I honestly don't have a good answer to that question, I'm afraid.
Right. So question here, expectations of sexual desires is different between the couples. Because obviously they're going to be different. How do we determine what's normal if one part of the couple has a different view to the other? What's normal? Because now we're talking about couples as opposed to individuals. So it's quite difficult to say what's normal in a couple.
Well, please go ahead, Dr. Pina.
No, I just see that the next webinar we'll talk about that. So.
Okay. That's a good answer. Okay, I think we've run out of all of the questions. Well, there's one here. Hang on a second. Do you think TikTok decreases sexual motivation and arousal? In other words, social media, does it have a negative effect on sexual normality?
Honestly, and perhaps this is colored by the kind of social media that I have access to and am engaged with. But overall, I found it to be a fairly positive thing in terms of providing opportunities for people to engage with their sexuality and to learn more about their bodies and how they work. Now social media, I think could certainly compromise real world interaction in favor of privileging screen time that is in many ways easier and less complicated. But just from the standpoint of knowledge about one's body and increased awareness, I find it to be a fairly positive factor.
Thank you. Well, I think we've come to the end of this interesting. Thank you very much, everyone, for all of these questions. I haven't been able to read them all out because they're coming quicker than I can actually read them out, and we'll have a limited time. But Barbara and Sydney, thank you very much for your presentations and a lively discussion. And I'll hand over to Omar just to give you the final slide.
Yeah, thank you very much, David. This is wonderful to hear Dr. Glenna and Dr. Barbara speaking on this highly kind of desired topic. But with that, I'd like to close the webinar for tonight. I hope everybody had a great time. And the next webinar will take place on March 23rd. That's about a month from now at 1 p.m. UTC, and we'll be on One Partner, One Sex, the Other Does Not. How to Handle Sexual Discordance in Otherwise Happy Relationships. Very exciting webinar, and hopefully we see you all there. And if you want to reach out again, any questions, comments, please, we're welcoming any feedbacks. And the recording of this webinar will be online as well. I think we have a link for that as well. And I'd like to thank Dr. Ralph and Glenna and Dr. Barbara Chubak for being here, and have everybody a wonderful day. Thank you.
Thank you, everyone.